Okay, it's 12 noon. I'm going to get started. My name's Rebecca Nevedale, and I'm with Tappy. And Macrina, do you want to say hi too? Hi, she's waving. When it's time to talk, remember to unmute yourself. So we are both with the Vaccine Coalition, the Arizona Partnership for Immunization. Our mission is to foster community wellness and advocate for good public policy and best immunization practices. And we have been doing COVID tips since January of 2020. So I think you all know us by now and who we are. And we have been on a whirlwind with you over the last 19, 20, 22 months, depending on when you started working in COVID response. Our cases for COVID-19 continue to increase. We, since the beginning of the pandemic, have had 1 million, almost 1.1 million cases of COVID-19 in Arizona. In the next day or two, we expect to surpass 20,000 deaths due to COVID-19. And at this point, this is, we've been talking a lot about how kind of desensitized we are to this number. This is an enormous number, an enormous loss to our state, to our community, and to families, that 20,000 almost families mourning the loss of a loved one. And at this point, they are almost all preventable. The COVID vaccines, no matter which one you get, are almost 100%, pretty darn close to 100% protective against death. And we are doing a great job getting vaccine out into the community. We have a ways to go. We have administered as a state 4.1, almost 4.2 million people have had at least one dose of the vaccine. 58.2% of our population has had at least one dose of the vaccine. And we are making headway on getting people fully immunized, getting those second doses. So last time we met, we were talking a lot about how we really needed to get second doses out there, and you all have done a stellar job getting your patients back in. We still have people who need to complete their series, but we are doing a lot better there. And a couple of weeks ago, I think 2 weeks ago now, you probably all saw on the news, 1 in 500 Americans have now died of COVID-19. That's actually 1 in 380 Arizonans who have died of COVID-19. So in a lot of ways, it kind of feels like we're in the midst of the worst part of the pandemic, because we are starting to see these kinds of numbers and seeing like what an impact this has made. And we are all very tired, and we are tired right alongside of you. Those of us who work in public health, we are tired of seeing sick people. We are tired of hearing about all of these deaths, experiencing them in our own families. We are tired of our families and our friends who we've been trying to talk to about vaccines for so many months now. But I think that it's really, as we start getting closer to holiday season and flu season, and we know that those things are all going to impact you and your jobs, we need to remind you that we are so appreciative of everything that you're doing, and we need you to stay in it with us. We are here to support you and to love you through it. We really need you to stay compassionate and stay connected to why you went into this line of work in the first place. And that's something that at Tappy, we are trying to keep our colleagues accountable to, is to stay focused on the reasons why we're in this line of work. And we hope that you can take the challenge to do that as well. And we also want to remind you that you cannot control everyone or everything in this pandemic. We all need to do a lot better job of staying focused on what we can actually control. So because it's a COVID tips and we like to have fun and be a little light, we have a 2-minute video to help you remember, let's all stay focused on what we can control.
You are a good person. You spend time with your family. You work out at the gym.
Come on, push.
You conserve water while showering. You like nice clothes. You give to charity. You recycle. You drive a Prius, but you use your bike when you can. You enjoy the occasional distraction at work. and you always send a card on Mother's Day. Always. But there's a part of you that tells yourself that you're not so good, that you could be doing more, that the world is falling apart at the seams and all you've been doing is yoga. One day you see that the rainforest is being destroyed at a staggering rate of 32 million acres a year. That's the equivalent of one football field every 78 seconds. You feel bad, angry, guilty. You've been apathetic for too long. You want to do something about it. You must do something about it. Well, this is what you're not going to do.
I quit!
You're not going to quit your job, leave your family, get on the next flight to Nicaragua, take a bus to the edge of the jungle, then hoof it across rivers, lakes, and streams on a quest to the very heart of the rainforest.
Take me to the heart of the rainforest.
You're getting closer. You're almost there. You have arrived.
You're not going to ingratiate yourself with the local tribesmen, go to great lengths to earn their respect and trust.
No.
It is around now you realize you're living out the cliche gringo fantasy of becoming an honorary native and leading the resistant forces. But screw it. If they could do it, so can you.
I'm gonna save you! This guy comes over here, I'm gonna do this, I'm gonna pull a zap-ding bats right through him, right over here.
You're not going to coordinate and occupy the rainforest movement, realize it's hopeless, summon the power of the gods, lead a revolution against the deforesters and their multinational employers in an apocalyptic, once-and-for-all battle to save humanity, only to awaken 2 days later in an El Salvadorian hospital with 2 toes missing on your left foot.
Siri, I wanna go home.
Hobble out of Central America, up through Mexico, across the Sierra Madre, where you break down, have your first cigarette in 4 years, accidentally start a wildfire, killing off the endangered species that once served as your occupational distraction, finally make it back home, only to find you've been replaced at work by a guy named TJ, and that things at home are not what they used to be.
Okay, so we cannot fix all of these problems. We've been trying to do that for 19 months. We're not going to do it, but there are things that we can control, and that's what we're going to think about today. So let's talk about processes. Let's make sure we all know what are these vaccines, who gets them, when do they get them, how are they packaged now? How do I bill for it? And just get grounded on the things that are within our sphere of influence. So, Macrina, let's start with who gets what when.
Okay, so there's 3 vaccines on the market still. There's Pfizer, which is 12 and older, Moderna, 18 years of age and older, and J&J, the single dose, the one and done, 18 years of age and older. So those are the 3 vaccines that are available. And so far, that's it.
Yeah, so that's it. So I know that a lot of our patients are coming in from other countries with other vaccines. Those are great. If you can't finish a series, because, say someone comes with 1 AstraZeneca and they need their second one, you give them a J&J, right?
Right, you give them a J&J. The other thing that I wanna point out is that all 3 of these vaccines, a new recommendation came out today regarding immunizing pregnant women and how important it is to make sure that our pregnant women are immunized. They are right now extremely at high risk. There are from the data we've seen, there's no risks identified with any of these vaccines. And for any potential risks, it outweighs the risk of actually getting disease. So make sure that your pregnant women talk to their provider about getting vaccinated. Okay, that's my speech.
Yeah, that's a good reminder. We didn't remember that this morning when we were talking. Yeah, glad you remember. But I just put in a link for that. You look on there and see. Look on there and there's really good talking points. Like the one that really jumped out to me was like a 70% increased chance of death, or
correct,
for pregnant women who do get COVID. So look on there, make sure you're talking to your patients or any pregnant woman that you see about COVID-19 vaccines. So if they don't have J&J, so someone comes in with an AstraZeneca, they don't have a J&J, do they start them on what they have if they have Pfizer in their office? Or
you can start them on whatever vaccine that you currently have in your office.
Yeah. Yep. So start them on something.
And then just follow that schedule.
Yes.
Also seeing vaccines that we don't recognize coming out of South America as well.
Okay.
If we don't have J&J, what we do is just go ahead and we usually wait the 28 days, 4 weeks. And then if it's been less than that, and then we go ahead and start them on whatever we've got.
All righty. So we know that there's tons of Pfizer changes. We're going to talk about those, but let's get the easy ones done first. So remind us storage and handling for Moderna.
Okay, so with Moderna, it can be stored in the freezer between -58 and 5. Just like any other vaccine, you're going to protect it from light, store in the original container. Do not store it on dry ice. Once you refrigerate it, it is good for 30 days at 36 to 46, just like any of your other refrigerated vaccines. Never refreeze it once it's thawed. You can handle it in room light. The biggest thing to remember about this vaccine is that once the vial is punctured, it's only good for 12 hours.
Yes. So get those patients in. And if you can't finish the vial, that's okay.
Correct. If you can't finish the vial, it's perfectly okay. If you have someone and it's the last patient of the day and they need their Moderna vaccine, and you have to puncture a vial to immunize that one person, you immunize that one person and you just toss the rest. Unless your clinic by chance opens at 3 o'clock in the morning, and then you might be okay. But I'm guessing, you know what, never miss the opportunity to put a vaccine in an arm.
And we would never take a Moderna out of the freezer, thaw it, and then re-thaw it, right?
Correct.
Right.
You would never take it out of the freezer, thaw it, and then refreeze it. So once you take it out, it's good in the freezer until the expiration date.
Right.
Once you take it out of the freezer and put it in the refrigerator, it can be there. And once it's defrosted, it's good for 30 days.
Okay, so hopefully that answers Jennifer's question in there. I think so. Keep it in the freezer till it expires.
Yep.
Okay, J&J.
J&J, or as I just discovered, is called Janssen. It has a silent J. I was on a teleconference on Friday. And this one is pretty simple, stored at your typical refrigerator, temperature 36 to 46 degrees. Once the vial is punctured, it's good for 6 hours. And up for 6 hours at room temperature. I think that's about it. Janssen is really simple.
Yeah. Okay, Pfizer.
Oh, Pfizer. It's the one with multiple personalities sometimes. Okay, so you can keep it in the freezer, your regular freezer temperature, which is whatever you have, you currently store your vaccine in, for up to 2 weeks. After that, you can take it out of the freezer and it can be stored in your refrigerator. Again, typical refrigerator freeze temperature 36 to 46 for up to 31 days. The packaging is 1,170 doses per delivery, which I know is quite a bit for some of the smaller practices. In November, December, they're going to bring that down again. For a small period of time, we were able to get 450 doses per delivery. This vaccine is the same. I don't know if I can't remember the next slide or not. If you do have an ultra cold freezer, it can be kept in the ultra cold freezer until the expiration date.
So this has changed, the storage and handling and these temperatures has changed a lot since we last met. So remember everyone to just keep looking at CDC's website. We'll always have what's most updated. And make sure you're signed up for the notices from your county health department and things like that. You know, when they make changes, everyone tells whoever is listed as your ASIIS contact, they are told a lot, but make sure you look at CDC's website too.
And what I just do on my calendar, on my Outlook calendar, because I'm like you, we all get a lot of emails and sometimes can miss something. I just put on my Outlook calendar twice a week to check the CDC COVID site. And then it pops up and reminds me that I have a meeting notice, and I go on and I give a quick look.
Is there a thing with the diluents for 12 non-diluent or diluents?
So currently with the 12 and up, we still use a diluent.
Perfect.
Some discussion from the manufacturer that between 5 and 11, there may be a smaller dose and it may be no diluent required.
But no one's immunizing anyone under the age of 12 right now.
Right. So I think the thing that everyone needs to kind of recognize is that we're currently going through this whole process very transparently. We've never done this before. We've never had so much information thrown at us. When a vaccine is being studied, researched, go to the FDA and then go to the CDC and the ASIIP. So just remember that all manufacturers will send out press releases and they get in the media and they'll give information. And then from that point on, they take that information and they go to the FDA, and then the FDA makes decisions. And then it has to go to the ACIP, who then reviews it, and then the CDC makes decisions. So I think the best thing that I tell the folks I work with, and I have to keep reminding myself, is that until I hear CDC, ACIP recommends this, I just listen to everything and keep it in the back of my mind as this is just information I to know.
Right.
Because we're not immunizing 5 to 11-year-olds, regardless of what the media is saying.
Yeah, and we've gotten calls from provider offices, so we just wanted to make sure that's very clear. CDC is the one we listen to. This is what they say, how we need to store things, and we're only giving to 12 and older.
Right.
So authorization has been a big hot topic.
So right now, 12 to 17 is under emergency use authorization. And for Pfizer, they have full FDA approval, which is ages 18 and over. It still goes through the same process, whether it's emergency use or full. It just means that with full approval, they have a little bit more data. Number one. Number two is with full approval, they can give it its own name, which is now Comirnaty or Comirnaty. I can't pronounce it. And now they can start advertising. So there are some little nuances that are different, but the data is all the same.
Right.
The data, whether it's an emergency use or full.
Okay, another Pfizer change. 3rd doses for immunocompromised.
Okay, so for this, it is 28 days after the 2nd dose. You should use the same product, but if you have somebody with you who is immunocompromised, who falls on that list, you can use whichever vaccine that you have available. And a lot of these are pretty severely immunocompromised folks. These are receiving active cancer treatment, organ transplants. We have a great friend who the day after this came out, his transplant facility called and gave him his 3rd dose. Stem cell transplant in the last 2 years. So there's the list you could see right there. So these are pretty high standard of immunocompromised folks.
So, and the thing to remember here is it's 28 days. Doesn't matter if you had Pfizer or Moderna. If you've had an mRNA vaccine, it's 28 days later, you get that next dose after your 2nd dose, 28 days after. And there was Robert had something in the post about their data emerging about mixing and matching. Yeah, there is data emerging for there, but right now CDC is still saying, if you got a Moderna, try and give them a Moderna. If you only have Pfizer on hand, then that's fine. Give them a Pfizer. So boosters ruined my weekend. I don't know about yours.
Boosters have sort of ruined the last 3 weeks.
Yeah.
I think there's been a lot of complicated messaging on the booster. I don't know how many of you had folks standing at your door wanting their booster on September 20th. But we finally got the final word on boosters. There's people 65 years of age and older and residents in long-term care settings. So we have a lot of data that shows that residents in long-term care settings or more risk. And so it's really important to get those folks the boosters. People 50 to 64 years with any underlying medical condition. People aged 18 to 49 with an underlying medical condition may receive a booster based on their individual benefits and risks. And that means that it's their decision to make. The list is very broad. It's anywhere from overweight, which puts me on the list for a booster. So you can find that site on the CDC website, and it's a very expansive list. And then people aged 18 to 64 years who are at increased risk for COVID-19 exposure and transmission because of an occupational institutional setting. And again, this is folks who feel that they are at increased risk for exposure, transmission, and disease. So this is nothing that you have to make a decision as someone immunizing or as a provider or as me as someone in an immunization clinic. I don't need to make that decision for them or ask for proof. If they feel they're at risk because of their career and what they do for a living, then they are eligible for a booster. Really, this was all put out to decrease as many barriers so that if folks want a booster, they can get one. And this is different than the third dose for immunocompromised. So the booster is the booster. The third dose is part of the primary series for immunocompromised folks.
So there's a couple, so we don't need to check their age. We don't need to check their occupation. You don't have to, a simple attestation is enough. Asking questions.
We're asking for no proof. We're not asking for proof of medical condition. We're not asking for proof of employment. We're not asking why you feel you need a booster. If someone comes in and asks for a booster or asks, do I need a booster? We just kind of go down this list with them and have the conversation. But if they feel that they need a booster, then we'll go ahead and immunize. So there's no pressure on you as the provider to have to document any proof.
So I think one of the other things we're finding is a little bit confusing for patients is the 28 days for the boost. So for the immunocompromised, it's 28 days after the second dose so they can complete their series. You want to get them a third dose. For boosters, we need 6 months. So if they come in with a vaccine card that says they received their second dose in June, that June was not 6 months ago.
Correct.
Yeah.
So we're not really going to face this whole booster dose after the third dose for a while yet, because we started giving third doses in August.
Right.
So they will be meeting to discuss if the third dose people need a 6-month booster.
And it is just Moderna. Are you getting that question?
It is just Pfizer. It is just Pfizer. There are no booster doses for Moderna. So I listened to the ACIP meeting about this. And so it does appear that Moderna has their immunoprotection is higher, a little bit longer than Pfizer. It has a little bit more mRNA in it. So they do see that it kind of stays at a higher rate a little farther out. So right now, people with Moderna do not need a booster. I'm sure that they will be having discussions about Moderna boosters later. And I know what causes some confusion is both Moderna and Janssen have put out press releases that says that a booster dose will be needed. But that doesn't mean that the FDA's looked at the data and approved it. It doesn't mean that the ACIP and CDC has looked at the data and approved it. So right now it's just Pfizer, and booster and Moderna folks are pretty well protected.
Yeah. And no, same with J&J. We don't have boosters yet.
We don't have boosters yet for J&J.
I'm going to launch a poll here and we'll move on, but we're curious how your sites are approaching the booster doses, not the immunocompromised doses, but are you doing anything to get people in for boosters at all? Or are you just kind of focused on primary series and getting people in for their first and second doses first? And I'll give you just a couple more seconds. What are you all doing, Macrina, when you look at this?
We're focusing our efforts on the primary series. We will give booster doses and third doses at any one of our clinics or community events. But as far as going out and doing booster dose events,
Yeah.
no.
And it looks like, I just closed the poll and I'm sharing the results now. It looks like most people are doing the same as Maricopa County Public Health. So focusing more on that primary series, not to say, you know, we know a lot of your practices like that. That's a great story about your friend's transplant team, calling them and giving them a vaccine. That's exactly who we want onboarded and activated to be given COVID vaccine. So yeah, you know your patient population and whether or not that would be important. And if you're doing other things, we'd love it if you would chat those things into the chat box, just so we can all learn from each other a little bit more. So do we need to verify completion of primary series? No.
Nope.
No. Risks? No. And will and J&J patients need boosters? These are questions that came in before. We already heard. Probably, but not yet.
Eventually, yes, but not right now. Yep.
What is going on with full? So we talked about Pfizer getting its full authorization, which means they can market more, and there's a few other things they can do. What's going on with Moderna and J&J getting full authorization?
So all I have heard is they continue to provide data to the FDA. And that's the approach, and that's the step they need to take. They need to keep supplying data to the FDA, and then they need to put in a request to have it fully approved. And the request from either one of them to be fully approved has not happened yet.
So they haven't done it yet. And children under age 12, stay tuned.
Stay tuned. Pfizer keeps giving more and more data to the FDA. Yet they have not filled out the application to have it approved yet. So they just keep paying attention. It's going to happen eventually, because this pandemic is we're not going to see the end of it until we get our children immunized. They're part of our community. They're part of our community. They spread disease just like everyone else. Sometimes more efficiently than most of us.
Yeah.
But that's why we love them so much, and just pay attention. We're hoping by the end of October, early November.
So tell all your pediatrician friends, please get onboarded and activated, because what do we know about young families? That's who they want to talk to. They want to talk to their child's medical provider. So their family physician, their nurse practitioner, their pediatrician. So please urge them all to get onboarded and activated, because we know that that's where many families are going to feel most comfortable getting this vaccine. So,
and we also know that a lot of adults who ran out and got the vaccine the minute they were eligible and it was available, even those uber pro-vaccine, they still have they have a lot more questions when it comes to their kiddos. So they really want to talk to their provider. They want a strong recommendation from the provider that it's okay to immunize their children.
Yep. So I'm getting this a lot at the vaccine events, at least that I go to, are we doing boosters because of breakthrough cases? So I'm sure others are hearing that. Are breakthrough cases common? Are they uncommon?
So it really, a lot of it depends on the setting and the age of the person. So we are seeing more breakthrough cases, especially in long-term care facilities where the immune response may not have been as robust as somebody else's. We're also seeing that those folks may be at more risk of breakthrough disease.
Mm-hmm.
I think what we're seeing is that probably breakthrough disease played a role in the need to get folks boosters. We do know that with breakthrough disease and the Delta variant, that we can see some transmission in breakthrough disease. And the fact that breakthrough disease is so is so the symptoms are so spread from asymptomatic and no symptoms at all the way to folks who do have more common symptoms of COVID. And keep in mind, now we're going to be moving into flu season where you may still be seeing some of the same symptoms. So it's going to get a little bit more complicated. So
but I think the big thing we need to make sure people know is that your vaccine is working, right? So
yes.
Is it more common than it was with the other variants that someone who's vaccinated would get COVID-19? I mean, even saying it's more common is like not the right words to use. Like, yes, it happens more frequently, but it's still not likely.
It is still correct. It is still very rare compared to the millions and hundreds of millions of people that have been vaccinated. And again, we're still seeing the most severe cases, hospitalizations, and deaths are among the unvaccinated.
Right, like well over 95% in some
correct
data sets. Yeah. So your vaccine is still working.
Yep.
So I know we're going to go over to billing now because everybody wants to make money. Are there any other questions that you all have about any changes with those products or? I'm not seeing. Oh, go ahead.
Hi. I haven't started doing any vaccinations in my clinic yet, so I'm not quite sure if this is the right forum or not, or if you guys are like 10 steps ahead of me. But at this point, I'm just trying to figure out like storage capabilities and like wastage. We have a family practice. We have about 4 medical providers who are a pretty small practice. I'm concerned with the amount of like doses that I need to order at one time and how I'm going to be able to store and utilize all that. I did see there was another website that said something about how to transfer or get smaller amounts, but the whole thing seemed very confusing to me. And so I just wanted to see if I can get some clarification on that.
So are you already onboarded and activated?
Correct. Yeah.
Okay.
We're onboarded, activated. I'm just, I've been hesitant to start vaccines in my clinic because of the large quantities of doses that I thought I was required to order. And I was concerned about the wastage once the vial was opened. Right. So, I mean, I see us probably being able to do, like a vaccination clinic type thing, a couple days out of the month, to make sure that we can utilize as much of the vaccines as possible. But I just wasn't sure how to order smaller quantities of it, like the Pfizer was like over 1,000 doses. And yeah, and if I'm going to get penalized then if I waste those vaccines because we're part of the VFC program. So I'm concerned that they're going to punish us for wasting those vaccines and I'll lose that program. So I just don't understand how that works.
So you will not get penalized for wasting any COVID-19 vaccines. So CDC has been really clear that they don't want us to ever turn down an arm.
Okay.
So we promise,
okay.
We know that that's hard to get off your chest, especially if you've had bills before, but it sounds like the transfer process would probably be best for you anyway, if you don't have storage to keep 1,000. And Jen, do you have a slide on that or a link for that in your billing slides?
I do. I was just trying to look at it to see if I could pull it up.
Yeah, there is a matchmaker app which allows you to find vaccine from other providers that may have the 1170 and can't use it. So you can transfer. This is the one thing that is then proves that this is different than VFC is you're allowed to really openly transfer vaccine among providers.
So, but then am I responsible then for packaging, shipping, delivery? Like, how does that all work?
I don't know how the matchmaker tools work. I don't know. Does anybody on this,
has anybody used it yet? Yes, you can click silver.
I don't know what that means.
Neither do I.
I don't either.
What does that mean, Jennifer, for transport? Is that a company or?
I don't know what Quicksilver is either.
Well,
This is good because we should probably know how that works better. And then we can follow up. Janelle, can you make sure to put your email in the chat? You can either put it to me or to Jen, and then it'll probably be Jen that she talks to DHS a little more regularly.
Okay, yeah, that'd be awesome because I've honestly been emailing and harassing and calling and nobody's getting back to me. So, you know, I'm meaning to jump on to one of these, you know, sessions for a while now. So I'd love to be able to get into contact with somebody because I really do want to figure out how I can, you know, get this vaccine, you know, in our clinic without, you know, a lot of wastage because I don't know, I don't want to waste it even though I know I can.
Yeah, we know that it's like counter to everything that you've been trained in. What county are you in?
Maricopa.
Okay.
Yeah.
Yeah,
So
we'll get you hooked. We'll get you info soon.
yeah, that's the piece that I need help with is just kind of figuring out, you know, kind of strategies on how to, minimize wastage, storage, you know, and I think I have the staff and the capacity to be able to, you know, come up with some workflows, but yeah, it's just the quantity and the volume and having to throw the, you know, the multi-dose vials out, you know, are you guys, do you know if they're going to consider coming out with single dose syringes at all so that there's less wastage with that?
I am sure that at some point the packaging is going to change because most facilities want single dose. Most vaccines have gone to single dose. I just think it's going to take them a while to get to that point.
Okay.
I don't think it's going to come quickly. I hope it does, but I don't think it is. And I think you investigating is really important because I have someone I know, and every time I ask him, has he gotten the vaccine? He says, yep, I want to get it, but I keep calling my doctor and he doesn't have it yet.
Yeah, it's
so he just keeps waiting for his provider because he says that's what I want to go to.
Right. And I do have a lot of patients like that. And I think, you know, generally, you know, when we administer flu shots, the patient's there in the office, I can just give it to them. You know, it's not that big of a deal, but the way these vials work, once they're open, you have to use all the, you know, all of the doses at once. You know, I'm going to have to kind of restructure my workflow, which I can do. But yeah, you know, it seems completely different from our usual ordering process and kind of this transferring and packaging thing, you know, is very like overwhelming for me. Yeah, if I can get some additional support with that, yeah, I'd love to start doing them in my office. And then, so I'll definitely put in my email there so that you guys can move forward. I did have one other question though, if you can comment on the use of COVID vaccines with administration with other vaccines. From what I understood, the only one that can be given with the COVID vaccine would be the influenza vaccine, and that all other ones need to be separated by about 2 weeks. If that, you can clarify that, that would be helpful.
You know, that recommendation changed when we started immunizing 12 through 15-year-olds.
Yeah.
Changed. So we can co-administer COVID vaccine with all of the vaccines. And we can give the vaccines any time frame afterwards. So there's no spacing issues, and they can all be administered on the same day. We've been giving pediatric vaccines along with COVID in our clinics since that day.
Oh, okay, good to know. And then what about the use of prednisone and COVID vaccines?
I do not believe there is any contraindication to that.
Okay, there was some hint early on that if they were on prednisone, then that again, the vaccine should be separated by about 2 weeks because prednisone could blunt the immune response.
Yes, and let me find that real quick. Jennifer, if you want to go ahead and go on, I will find the answer to the question.
Thank you.
You're welcome.
All right. Yeah, we were saying earlier, if you haven't checked the CDC's interim guidelines in the last 5 minutes, then there's something probably different. Am I showing the right screen, Rebecca? Is this the don't waste an arm?
Yeah, she's really, I like your riveter. Your Rosie
I
riveter.
like her
She's
too.
good. Yeah.
Yeah. I thought so too. So yes, they have been very clear. And I know if you look on the CDC's website, it'll say, don't waste an arm, but do everything that you can to protect this vaccine. You know, because of course, we really do want everybody to try to do bigger clinics. However, we are at a point where there are millions of doses in the US, and we've been able to share millions of doses with other countries. Some are even getting close to expiration, so we don't want to waste them by throwing them out. So they do want to say, you know, if you can give one that day, if you've talked to a patient that day and they've said, yes, I want the vaccine, and you're not going to see anybody else, give that one dose to that one patient and throw out the rest. At this point, it's too expensive for them to go to a single dose presentation. So it's cheaper to put a whole bunch of doses in that vial than it is to do the packaging on all of the single dose they would have to do. So it's actually cheaper to throw away those extra doses than it would be to do a single dose presentation. And we don't want to miss that arm now, because now we're down to those, you know, really those patients who are really hesitant. And we know when they're in the office and they're talking to you, and you've kind of, you know, built that trust, that's going to be the moment that they say, yes, I'm ready to get this vaccine. And if you, you know, tell them, we'll find a clinic and, you know, or come back next month, you know, it's less likely that they'll follow through. So give it to the person there. There's no mechanism at this point to be able to replace those doses like you do with BSC. So you can't purchase a private sector dose to replace that, because there is no private sector doses. So you know, you're not going to get the letter to say replace the doses that have been wasted, and it is not going to count against BSC. These are two separate programs. They're counted in two separate ways. And so they're getting more and more clear about that, but you know, in kind of, you know, CDC speak, they can't really be as clear as I'm trying to be right now. Don't waste an arm. And then I think, thank you so much for sharing the information about Quicksilver, because none of us knew what it was. But this is the ADHS Matchmaker app that they just rolled out. So this is if you're one of those offices that you don't want 1,100 doses, or you don't even want 100 Moderna, you just want 50 doses, or you want 200, join this Matchmaker app. All of the county health departments are listed on this app, and the county health departments have been able to take those really big doses and then break them up for other offices. So you can request the number of doses that you want through this Matchmaker. And if you have extra doses that you think you're not going to use, you can post them onto this Matchmaker app as well. So another office near you can get it. So this is the link, and we can put the link in the, oh, look at that, Laura Smith already got it in the chat. So use that link to get those smaller doses through this Matchmaker app. And then I kind of switch these around. The other thing, the other request that we're hearing very often that ADHS has put some new resources up for are lost patient records. So you hear from a patient, they can't find their record, they want a copy from you or try to help track one down. There is now a patient request form through ADHS at the one link, and this one will allow them to make that request to ADHS, and then they'll send them a copy of their record. This is taking a very long time, however, because they're getting millions of requests. And so they are trying to get through them as fast as they can, but the volume is pretty high. The other option is to try what's called, it's a new app called MyIR, My Immunization Record is what it stands for. So if they gave the correct information about their address and their phone number, they should be able to use the MyIR app to input their information, validate that, and then pull down their record. The other thing that you all can do is to go into ASIIS, just like you would look up a child's record. You can also look up an adult's record and pull a record from there if you want to help them out. You can also update their patient information, their demographic information, so that it matches the information that they need to pull it from MyIR. So those, and then
when they have a patient that says, I went on MyIR, but I didn't find my information's not on there, what should the provider do? Direct them to that patient record request form?
Direct them to the patient record request form, or if, you know, if by some miracle you have a lot of free time or someone in your office does, you all, as their as their primary care provider, you all can go in and pull that record out of ASIIS for them to at least help them understand which brand they got, what date, you know, especially if you're talking about boosters and that third dose immune compromised.
So would there ever be a situation where they would be entering in, like if a patient comes with their card, can they enter in that historical, or should they not do that?
All providers who have an ASIIS login can put in the historical data. So if you know that your patient has all of the shots in ASIIS that you've given them, their flu shot every year, their Tdap, their shingles vaccine, you can go into that record and you can put in historical data. So instead of entering it in as shots given today, you actually click on historical and you put it in as a historical shot. It's going to have an asterisk on it on their record when you look at it, because it's a, you know, you didn't give it, you just reported it as historical. So chances are there is going to be a record in there in ASIIS of where they received that COVID dose, but maybe it didn't merge with their patient record, or they can't find it, or there was a typo in how they registered for it and they're unable to pull it up. So that'll help kind of merge it. If you can find their COVID record and it's different from their flu shingles record, you can request that ADHS merge those together as well.
Thank you.
But it's a lot. There's a lot of patient records in there. It's a lot of data. It's a lot of information to cut through. We also have some free materials for education and outreach, and happy to help with any of that if you need it. Just reach out to us. And email with those questions about, you know, kind of how many do we need, how much do we store, what do we think about doing for setting those up. We're happy to help try to find some experts and some other offices that have done it and have some, you know, some tips to share. But really, I came today to talk about billing. There are some really exciting things in the world of coronavirus vaccine billing, and then there's some really frustrating pieces. But we'll start with the very, very good news. Most of you know, and you have been billing for the $40 per dose for Medicare and private sector. Now Medicare has added a $75 admin fee if you're seeing homebound patients and you take the vaccine to them. So that means for 2 doses, it's $150 would be your reimbursement for a homebound patient. So that's phenomenal, because we know we had a whole lot of patients who don't have transportation, can't get to their to those clinics very often. Now you can get to them and cover the cost for that. And then the really good news is ASIIS will reimburse any access provider out of network. If you're not contracted with a particular plan, they will reimburse you at $83 for that admin fee. And that is huge. And it's a big difference. So that's for anyone age 12 and up. If you're carrying Pfizer, the admin fee for ASIIS across the board is $83. So make sure that you change your fee schedule for that for Medicaid patients in your billing systems, and that you're not still billing the 40, so you get the full reimbursement. The uninsured and underinsured program are still going. Here is just a guide for based on date and payer, what you can expect that payment to be and what the cap is for each one of the, what is it, Janssen? Is that how you pronounce it, Macrina? You'll have to teach me again. But the J&J and the Moderna.
It's Janssen.
It's Janssen?
Yep.
Janssen. Yep, there you go. Now, the more complex, this is the part where, you know, I think we're all kind of tearing out our hair a little bit. The Pfizer vaccine has now has 2 additional codes. So you've got the vaccine code that you bill 0 amount for, then you bill the admin fee for the first dose code, the admin fee for the second dose with the second dose code. Now we have a 3rd dose code for Pfizer, and we now have a booster dose code. So when you have an immune compromised patient, you will bill the 3rd dose Pfizer code of 0003A. And then the next patient that comes in and they need a booster dose, you will bill 0004A for booster doses. So even though both patients are getting their 3rd dose, One is called a booster dose and has a different code. And essentially the way that CMS kind of defines this is an immune compromise. Somewhere in your medical record, you have to report or record that the patient has self-reported as qualifying as immune compromised. So that could be a checkbox on a list. You know, you're here today for your vaccine and you are checking a box that says you are immune compromised for your 3rd dose. Your booster dose, you do not have to have any additional documentation in there, but you do have to build the other admin code. So it's going to get pretty confusing as if it weren't already. Just some reminders that you may not seek reimbursement from the patient, so you can't balance bill them. You can't charge them out of pocket for that. The other thing I want to point out that's kind of a concern on this one is we've actually seen some plans who have patients who automatically have their health plan connected to their HSA plan. Some of the health plans are pulling that out and paying providers from that HSA account, and that's actually not the way that this is supposed to work. So many of the health plans right now are working on national projects to reimburse the HSA account and pull that from their medical plan side. But you may notice that you're getting some HSA payments, in which case contact that insurance carrier to make sure that they know that they need to revise their system. The uninsured and the underinsured programs through HRSA will help you recoup those costs that you were not able to get through billing. So if you have a patient that is uninsured, you can submit that to HRSA for full payment of $40 for that admin fee to HRSA for an uninsured patient. If you have an underinsured patient, or this is a payment that you got that was below the $40, so if you built the plan and they reimbursed you at $15 for the admin fee, you can submit that claim to the underinsured program and they will give you the difference between the 15 and the 40. They'll make you whole for that. Both of these programs are kind of complex. It means you do have to submit these claims a couple of times. Through the uninsured program, you've got to get a patient ID number that then you take back and you add to the claim, and then you resubmit it through Optum. And the underinsured program, you have to submit first to their insurance plan, get the denial or get the low payment, and then resubmit that to the underinsured plan. But if you're noticing you're getting quite a few of those, it really does help to make you whole and know that you haven't lost anything on these. So it is an insurance, kind of a insurance of the insurance program. At whyimmunize.org, under the provider COVID resources, we do have 2 full slide sets of billing guides, one for the underinsured program, and then one for just general billing if you need any information and more information about that. This is just kind of an overview of how you would set up that claim. I think the most important thing here is to say the biggest change is that you can bill for flu and COVID-19 vaccine. You use the COVID admin code, whichever one that it may be, and then you use the primary flu admin code of 90471. So instead of the flu being considered a second vaccine because of the 2 admin fees, you have to submit for the primary flu. So you're going to get full payment for both of those. That's the good news. The bad news is if you're billing Medicare, COVID claims have to go directly to Medicare through Noridian or, as their Part B coverage. If they have an Advantage plan, you have to bill COVID to Medicare and you have to bill flu to the Advantage plan. So as confusing as COVID has been through the vaccine, through this whole thing, the billing is just as confusing or more. We know. I think that was it for me.
I know that the question of what do you do when a patient doesn't have a social security number? Do I have to collect? Can you go over that again?
Yes. Now that's okay. So when you're billing Medicare, you have to have their Medicare number, not their Advantage plan insurance number. If you don't have their Medicare number, you have to ask for their social security number because that's how you bill through Medicare. Then the other side of that the Social Security number, they'll also ask you for a Social Security or driver's license for the uninsured program in order to submit an uninsured claim. If they have not provided that, and if you don't have it, there is a box that you can check on the uninsured program that says this patient did not share that information, in which case they'll give you a temporary number and you can submit it anyway. So you don't have to have a Social Security or driver's license to get this vaccine, but on the provider side, it's going to be easier for you if you can get a Social Security number, Medicare number, or a driver's license number. Clear as mud, right?
But it's not necessary. I think that a lot of patients are uncomfortable with the question and being asked at all. So just make sure whoever's asking for that information is properly trained to make people know that we're not, you're not reporting that to anyone, that they have or don't have a Social Security number. And
yes, and I was trying to see if I have it on here and I don't. We actually have a handout. What?
I just said, oh yeah, we have a flyer for that.
We do. We have a handout or a flyer that explains to the patient, these are the things that you might be asked for when you get your COVID vaccine. You do not have to provide them. However, it is much easier for your office to be able to bill this if you do. So we have kind of a nice way, and even if you don't use it as a flyer or a poster or whatever, maybe it's a good way to, train staff on how to talk about it. Because yes, if you ask a Medicare patient for their Medicare number, they will give you a whole litany of reasons as to why Medicare has told them never to share that number. And now you're asking for it. So, they have been very, very well versed in never share your Medicare number. And now we're saying share your Medicare number. So we do have some guidelines on how to do that. I'll find the posting of that and put it in the chat. Oh, look, thank you, Laura. Man, she reads my mind.
There you go. Anybody have we have about 3 minutes left, but we can probably hang on for a little bit of time if people have any specific billing questions. One thing that got uploaded to the chat was just clarification that if a patient is on prednisone, it is not a contraindication to any of the COVID vaccines. Any other billing stuff? Are you getting paid for your third dose immunocompromised yet, Jen?
No.
No.
No, and don't be discouraged when you get those denials, because it takes a while for the health plans to load all of those codes and get their system in place. So third dose and booster dose, you're going to get a whole slew of denials come in the beginning, but just hold on to them for a little bit and resubmit them. They are catching up.
Oh, great. And
yes.
So TAPI does,
for those of you
who don't know, TAPI does the billing for all the county health departments. So there's a question from one of your counties in the chat.
Yes, we are submitting to the underinsured and the uninsured program on behalf of the county health departments, because of course the safety net, the county health departments are really supposed to be the ones that are capturing those and making sure that uninsured are vaccinated. We are submitting those, however, and we're reporting those monthly to the county. However, we are holding on to that until we can get some clear guidance from the CARES Act pieces. So, and for any provider offices who received like one of the PPP loans or the CARES Act loans, and for county health departments that have received CARES Act funds, you may have to report the billing funds as additional income to the CARES Act. So if you've now billed uninsured and you received a loan, there is a different reporting way that you have to, talk about that as income. So we're still waiting for federal guidance on that. And that might be something that some of the offices want to look into as well, if they had received any of the provider loan funds. And I did see there was a notice yesterday that there are additional loan funds available for provider offices, especially in rural areas and communities, because they know that COVID is still really impacting business for our healthcare systems.
All right, well, it's 1 o'clock. We can keep the line open for a little bit in case there's other questions that come in about product or about billing, but we are so appreciative that you are sticking with us through this pandemic. We really hope that you remember to stay connected to why you do this work. It is so important. You get to save lives every day, and you are our way out of the pandemic. So thanks so much for everything you do. We are here to help, and we will be back again. Hopefully, fingers crossed, when we go down to age 5 for Pfizer. But if not, I'm sure within a few months, there'll be more changes that we'll have to make sure that we tell you all about and answer any questions. So thanks so much for what you do.
Thank you all.
Yeah,
It has not been an easy year and a half.
But you know, working in the immunization field for a very long time, I don't think I'm ever going to complain about a complicated schedule about any vaccine ever again.
Yeah, right.
I think
No.
it's made rotavirus vaccine just as clear as mud, and pneumococcal 13, 15, whatever, it's all out there.
I keep thinking about when we started HPV and how we just thought, there's so many times I think to myself, wow, we were so wrong in how we were thinking. Like, how many times have we said, all we need is not that we were wishing a pandemic, but we would talk about vaccine hesitancy and say, if people just saw disease again, they would all be, running for vaccines. Well, we learned that was wrong.
Right. We all kept saying, all we need is one real good outbreak.
Yeah.
We get a good outbreak, we got a great pandemic, and we still have these challenges.
Yes. But I keep thinking about HPV too, and uptake and how slow that was.
Oh, HPV was a piece of cake.
No,
Retrospect.
I care about kids the most, and pregnant people who are about to have kids too. So, but these numbers for our 10 to 15-year-olds, and then we look at numbers to ages 10 to 14, and then 15 to 25, and they're just so low.
Yeah.
Much lower than I think
I've had a lot of talks with a lot of parents who were right out there. I mean, they were out there the minute the vaccine was available and their group came up, they were right there. They went at 2 a.m. to a state pod to get a vaccine, right? Yeah. But even with their kids, they want to talk to their provider. They have some questions to answer. I mean, I think when it comes to kids, parents are a little bit more cautious. And so I think when it comes down between 5 through 11, I think if offices could get vaccine, that would be rainbows and unicorns for me. But at least that resource there to have the discussion with parents about how important it is to get them immunized.
Right.
Yeah, 70% of parents prefer to talk to their doctor about a COVID-19 vaccine for their kids.
Not any vaccine or potty training problem.
Yeah.
I mean, not everything. They want to talk to their doctor, their child's doctor.
And that's how it should be.
Yeah.
Right? That's how it should be. That's the idea, is you build those relationships and that trust.
Mm-hmm.
Anybody wrestling with anything with COVID vaccine these days, or is it going smoothly now that everybody has the flu?
Smooth. The flow, when you have people right there who've come for the vaccine. Yeah. Some patients still refusing. Yeah. Tappy's been doing this community education program where we put doctors and nurses in community organizations, and they just answer questions about vaccines. And yesterday, one of our volunteer physicians, and I don't know if he's on or his office is on or not, but went to a long-term care facility. And after he left, there were some people from the kitchen who were all talking about quitting their jobs because they are now going to be required to have the vaccine to continue working there. And that conversation with that doctor and to get those questions answered, they're not quitting their jobs like they're thinking about getting vaccinated. So yes, people are refusing, but they are changing their minds too. So having issues with people coming in. Oh, this kind of makes me laugh, Macrina. Having issues with individuals coming for the second dose much later than their return date. Like, I wish they were doing that in the beginning when we had no vaccine.
Right.
It's okay if it's not exactly 21 days. Everyone needs to stop. It's okay.
Yeah, it's okay. Yep.
Try to get them in. He's trying to get them in on close to schedule, but people gearing up for this booster, restarting the process. Yeah.
Well, I mean, how many times has my doctor said I'm due for my mammogram and I still haven't gotten there, So it's now taken, 6 or 7 reminders from him. And it's not that I'm against mammograms, I just don't have time and we're in the middle of a pandemic. But, now by the 6th or 7th time, I'm feeling so guilty. I'm like, crap, I have to go back and see him next month. And I have to get my mammogram before I do, or I can't walk in there. So eventually that nagging does get through.
There's a good shout out to Health Checks and Chinley. We cannot brag about you all enough. And we do often, huh? Yeah.
Oh, all the time. And I'd love to do that on a national level where people say, oh my gosh, Arizona, that must be really tough for vaccines because you're a border state and you have the largest reservations in the country. How are you managing all of that? I'm like, well, we go up to the Navajo reservation and to the reservations in Southern Arizona, and we ask them, how do you do what you do? Because you have the highest rates in the country. So can we learn what you're doing and replicate it everywhere else? So it is. We brag all the time.
Mm-hmm. All righty. Well, I don't think we have many questions on billing, which is good. Elderly couple refused because they think it made them feel tired, fatigued, and other health issues will develop more than it is now. It is really hard to put these, like, what is a normal, should be expected immune response into perspective. There's some good charts and graphs. I don't know if we have any of them showing like the incidence of certain conditions for COVID positive patients compared to vaccine patients, people who've had vaccines. I know that they exist. Do we have them on? I think we have them in our slides somewhere. But it is hard to put that in perspective.
I think it's also really hard for people who've never known anyone who had COVID or knew somebody who had COVID, but it was a mild disease. So, I think somehow it all goes about that. How do you personalize it? And so I know that what's motivated a lot of people I know is when loved ones get extremely ill on a ventilator, who's 44 years old, or, when somebody who you're used to seeing every day you take your car in for an oil change has passed away. So I think part of that is how do you, those stories, it makes it more personal.
Yeah.
Well, and even for some of the scarier things, like, the concern about myocarditis and in some younger people who had the second dose, you're still 7 times more likely or 9 times more likely to have myocarditis with the virus than with the vaccine. And it's still relatively low, but the virus itself can create so much havoc.